Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Benjamin Kielsen from Brussels, Belgium. Dr. Kielsen is a biomedical engineer specializing in medical physics and imaging. After earning a BSc in biomedical engineering from the University of Science and Technology in Ghana, he completed an inter-university master's degree from the Vrije University in Brussels, Belgium, and the University of Ghent, followed by a PhD in dynamic CT imaging for musculoskeletal applications from the same institution. Currently a postdoctoral researcher at the Department of Electronics and Informatics and the Radiology Department at the University Hospital in Brussels. His extensive experience in designing image acquisition protocols and developing automated image segmentation workflows. His work focuses on enhancing diagnostic tools for dynamic musculoskeletal imaging. He is now building a venture to provide clinicians with an AI-assisted platform for analyzing CT images or joint movements, addressing the unique challenges of dynamic musculoskeletal imaging. So today it's my great honor to introduce you to Dr. Benjamin Kielsen from Brussels. Over to you, Benjamin.
All right. Okay. Thank you very much for the really nice introduction. And it's an honor to be given the opportunity to talk today about our work on dynamic CT MSK applications. So I will begin. This is how my presentation is basically going to go. I will start a bit with some basic principles in medical imaging, basically what the concept of medical imaging are about, because it's essential to be able to grasp some of these principles to then deep dive a bit into dynamic CT, particularly focused on musculoskeletal applications. There are aspects of it that might be a bit technical, so therefore I'll be more than happy and open to questions, and I'll be looking forward to providing some answers to these questions. So that's a bit of how my presentation is going to go. But first, I'll begin with a bit of context. So actually, most of the work that I'll be presenting today was part of my PhD and also part of my postdoc. And it was funded by a university research project known as the Interdisciplinary Research Project. And from the name, it meant it involved multiple research departments in our university here in Brussels. We had people from the orthopedics department, as well as people from the radiology department in the hospital, and then the engineering department, so mostly for the image processing aspect of the work, and also people from the experimental anatomy department, which is known as EXAN. And my activities were actually between the engineering department and the radiology department. So I actually had the opportunity to work with a lot of great orthopedic surgeons as well, and that's what motivated the way this work evolved. The image processing aspect of the work, and also so I'll begin with a very straightforward question. What are medical images? It's an umbrella term for all images that are generated from various techniques that allow us to visualize internal structures of the human body. Basically avoiding having to cut the patient open to try to just diagnose a condition. And it has revolutionized the way we do healthcare delivery in the world, because it allows us to diagnose, detect, and monitor a lot of diseases, and also importantly, to follow up patients after whatever intervention we do. Now, if you strip down the concept of medical imaging, essentially what you're trying to do is you're passing some type of energy through an object or a body or a patient, and you have a detector on the other end, and you want to collect some of this energy, and based on that, you want to infer some information about this object or structure. So for instance, in this case, by looking at these 2D projections, you infer that the structure you're looking at is a cylindrical structure. Now, what differs in the type of imaging modality is the energy that is being used. And for that, I'll take you a bit back to the concept of electromagnetism. So here is the electromagnetic spectrum, together with some associated household equipment that we know are familiar with some of these electromagnetic energies. And you have from the lower end energies all the way to the high end energies, and that's where X-rays actually sit, because they have the energy, or you can split them into what we call non-ionizing radiation and ionizing radiation, where ionizing radiation basically means these have enough energy to penetrate the body, and that's basically how we're able to gather some information from these type of images. Now, the fact that they can penetrate the body also means they have implications. So it's important to also take into consideration that using ionizing radiation is not like taking any other pictures, and it's important to take into fact that say, well, yeah, there are some risks to doing these type of images. So with that being said, imaging in the MSK system, I guess a lot of you are familiar with the very most concepts as of CT or of X-rays, which are 2D images, but they are a representation of what is actually a 3D structure. So it gives you some good information. However, you don't have enough details. If you were to go to a 3D modality like CT, what you actually can do is you can scroll through these images. You have more detailed information. You can do so from different projections or views. And again, basically allowing you to see more context. Now, how it's able to do this is because it has an X-ray source, which is then generating these energies I talked about, X-rays, and you have a detector on the other end, and you're basically collecting what goes through the object or the patient. And based on that, you're able to infer or make images. If you strip down the CT scanner, this is what it basically looks like. You have an X-ray tube that's rapidly rotating around the patient, and by doing so, it moves the bed as well, and you're able to sort of slice the patient up into these slices, and that's what you can scroll through to get more detailed information. Now, there are multiple ways of doing or acquiring these type of images with the CT or the scanner, and that's what we call the scan modes. Essentially, we'll strip them down into two. We have what we call the axial scan mode and the helical scan mode. Now, in terms of axial scan mode, your X-ray source is sending energy through the patient, then you collect the data, and if you want to scan another region, you basically have to shift the table and repeat the process. So you scan, shift table, repeat the process. That's basically the concept of the axial scan mode. On the other hand, in terms of helical, the X-ray production and the movement of the table is simultaneous. So the X-ray source is rotating around the patient, the table is moving as well. So you end up forming this sort of spiral around the patient, and that's where we have the helical scan mode. Now, depending on what's your interest, you might use one or the other, but they all have some benefits and some downsides. For instance, this process of Excel scan mode is a bit slow because you need to scan and then move the table before you do the next scan. And it's also susceptible to motion because if your patient moves in between the two distances of scanning, then you have artifacts in your images. So basically the quality of images degrades. On the other hand, the helical process is much faster, but it's also prone to higher radiation dose. So depending on what you're looking for, you would go for one mode or the other. Another mode that's actually also very interesting is what we call the cardiac scan mode. Now, there is a special mode dedicated for the heart because it's a bit of a complex organ to scan because it's beating rapidly. And especially if you're interested in the coronary arteries, which are very small, then if it's moving, then your images are very poor quality. So what you try to do is to scan the heart in a region where it's a bit more stable. And studies have shown this around the 75th percentile of the heart rate. So if you were to split up the heart rate over a percentile, around the 75th percentile of it is when you actually get these coronary arteries nicely scanned. So what this implies is you need to be monitoring the patient's heart rate. And at that point, maybe you can turn on the scan to scan when the heart is in that nice sweet spot you want. On the other end, you can actually also just scan the patient and then retrospectively pick the regions of this sweet spot. So these are some of the new modes in cardiac. And I actually talk about it because this cardiac mode has been one of the drivers in when it comes to some of the recent advances in CT technology. And I'm going to try to explain that. So like I described, you have an X-ray source that's emitting energy and you have a detector. Now, imagine you want to scan the heart, which is an around 12 centimeters or so structure, and your detector width is about 2 centimeters. That would mean you need multiple positions to be able to capture the entire heart. And this has its implications, like we explained earlier on. For instance, it can introduce motion artifacts, and then your image quality is also bad. So one of the main advances in CT technology is the development of these wide beam scanners. These are, for instance, up to 16 centimeters, meaning you can scan the entire heart in one rotation without having to move the bed. And by doing so, you eliminate the challenges that we just described before. And these are some of these CT scanners that are allowed to do this process. In addition to just not the wide detector beam, they also have a very fast tube rotation time, meaning they rotate rapidly around the patient. And again, that will help you reduce these type of artifacts in your images. Now, the reason why I bring this up it's coming back to dynamic CT for MSK applications. Now, I again show you an image, an X-ray image in this case of the hip with an implant. And well, you see some details, right? But if you were to do an actual CT scan, then it highlights a bit more details than you see from the X-ray. For instance, you now clearly realize that it's actually not one unit. You have the cup, and then you have the stem of the prosthesis. And there is something actually happening here. There's something has gone weird over here. If you were to do a dynamic scan, if the patient were to move, what you realize that at some point, and this is not, sorry, the best of images, but at some point, this prosthesis is coming out of the cup. And this, for instance, could be the cause of discomfort for a patient, which is information you would not get from your X-ray, your standard X-ray, or just from your standard CT, static CT images, but only if you're able to obtain these 3D information over time. So that's basically the concept of dynamic imaging. And what we do there is we actually exploiting a well-established clinical imaging modality, which is the CT scanner, and leveraging the advances that I just described. The fact that now you have a wide detector, meaning you can, for instance, have a patient in the scanner or the knee of a patient in the scanner, and then you rotate and obtain an image. So that basically gives you one CT scan. Now, if you were to do this multiple times, you are definitely then generating multiple scans of the same region because it's wide enough, you don't need to shift the table. And imagine this patient is now moving the limb in the scanner, then what you actually end up with is images of the knee at different stages of motion. And this is further highlighted here. For instance, here is a case of a subject simulating the thumb motion, retropulsion motion, and you're able to continuously scan and then obtain images describing the entire motion. So you end up with these stack of CT images, which you can lump together to create these type of dynamic or 4D images. So they're already quite intuitive or insightful to look at these images. You can already get a lot of information from them. But what we also wanted to do was to add an extra layer of being able to obtain quantitative information from these type of images. Now, this is where you need to rely on image processing techniques because you cannot expect radiologists or orthopedic surgeons to spend their time trying to analyze the numerous images that dynamic CT generates. It generates images in the 4,000 or 5,000 images. So you need to find a way of processing these type of images to extract the best kind of information from them. And two important techniques are necessary for this. That's image registration and image segmentation. Now, I'll try to explain a bit what they are. When you talk of image registration, now what I described on, you have, in this case, is an ankle image obtained at two different time points, time point 0, time point 1. If you were to overlay these two on top of each other, you see that there is a mismatch. The concept of image registration is basically you're trying to find a mathematical equation or description that can allow you to nicely align these objects on top of each other. So then you end up with this mathematical equation. And from this, you essentially have the way this bone moved in time. So you have information on how the bone moves in time. So that's the concept of image registration. On the other end, you have image segmentation, where basically you're trying to delineate your structures. You're basically trying to separate structures of interest, in this case, the bones from the surrounding soft tissue. And here we're able to say, okay, this is the tibia, this is the talus, this is the calcaneus, and you're delineating that from the rest of the surrounding tissue. Now, these are very important processing techniques that are essential for any further automatic processing you need to do, which we'll see down the line. So based on these principles that I've described, what we wanted to do, particularly in that project, was to establish a framework that will allow us to quantitatively analyze these type of 4D CT images. Now, in order to do that, we realized that it's important to ensure that the quality of the images you're getting from the scanner are good enough, because if they aren't, your processing will also fail. But on top of that, because we are using ionizing radiation, it's important to take into consideration the patient's safety. So you need to design protocols which are safe, but that also generates good quality images. So that's one of the first bottlenecks to overcome. The next step is the fact that, well, like I said, the technique generates thousands of images. So you don't expect anyone to try to manually analyze these type of images. So it's important to establish a workflow that can allow you to robustly, automatically analyze these type of images. And once you've managed to fix these two challenges, the next step would then to see if you can explore some clinical or preclinical applications of this technique. So these are the blocks we try to follow, and the rest of my presentation will sort of touch on each of these blocks. So to begin with the scan protocol optimization, it's actually a balancing game. It's a power play between image quality on one end and dose, or the radiation dose, basically the patient exposure on the other end. When we talk of image quality, what we are actually concerned about is what we call motion artifacts, because we are purposefully asking the subject to move because we want to get this dynamic information, but then that has implications on the quality of images you generate. So that is one thing to take into consideration. On the other end, well, so here's an example where you see the consequence of moving too fast. You see you have like this artifact or a doubling of the bone, which will have implications if you want to do any automatic processing on these type of images. On the other end, you have the patient safety. And here what I show is an extreme example of what is known as radiation-induced alopecia, basically as a consequence of repeatedly scanning over the same region, right? So it's important to try to take that also into consideration, that things can go wrong because you're using ionizing radiation. Now, the way of ensuring this or playing or managing this balancing game is by controlling the parameters you give to your CT scanner. So this is the scan mode, the tube voltage, the tube current, and these are the parameters you play around to ensure you have good image quality on one end, but you're also not overlooking the patient safety. So with that in mind, one of the first studies we did was to investigate if we can create a very low dose scan protocol, so significantly reducing the dose, and see if that low dose is able to generate images of good quality enough to, for instance, detect kinematic changes. So what we did was to now settle on this protocol. I'm not going to go into the details of it, but it's a protocol that significantly reduces the radiation dose to the patient. And we did a cadaver study. So basically we had the ankle placed in this custom-made device that allowed us to simulate flexion extension motion. And then we tried to see the implication of cutting some ligaments sequentially in this cadaver. So first of all, we scanned it when the ligaments are intact, and then we cut, and then we do the dynamic scans again. And sequentially, we increasingly cut these ligaments and see what the implications are on the motion of the joint. So here are some qualitative results. On the top half, what you're looking at is the intact scenario, so when all the ligaments are fine. The lower part is when we cut all the 3 ligaments. Now, what you can observe is during the motion, if you look at the gap here, in the intact scenario, this gap is smaller than if you were to look at it in the scenario where all the ligaments are cut. This can also be observed on this other view of the image, where you notice that the gap here compared to here is larger in this case here. So, but this is quite qualitative. You probably will have to squint a bit to figure out what's going on. So what we are trying to do is, can we also quantify this? Is there a way to quantitatively represent this? And that's where we rely on the image processing techniques I talked to you about earlier on. So image registration and image segmentation. So here is an example of an attempt at an image registration where you're trying to align the 2 images on top of each other. The challenge here is the fact that, well, you have multiple bones, you have soft tissue around, and these bones are also slightly moving in different directions. So doing a pure easy registration is not that obvious. So what you can do, or what we introduced, was a segmentation, where basically we delineated the structures of interest. And once we have these individual structures, we can now then perform individual registrations for each bone separately. And we do this over all the different time points we have. And it's from this processing that you're able to extract the quantitative information. Now, this is a bit of an overview of the entire workflow. Again, not to bother you too much with the details of it, but you have your dynamic images coming in. You manually segment the structures of interest, so delineate them, and then you feed that into your registration process. So here is the results before registration and after registration, where you see that all the bones are nicely aligned. And it's from this process that you're able to extract the mathematical information that describes how the bone is moving in 3D space. So with that said, imagine now you have a point on top of your bone. By virtue of motion, this point is going to move to a different location because the joint is moving. And from the description of the mathematical description of the bone, we can, for instance, then track the motion of this landmark. And that's what we did here. And here, there were a lot more results. I'm actually just showing one particular one. So in blue is the intact scenario. So when all the ligaments are intact. And the other graphs basically show the different lesions introduced on the ligament. And you can tell that we can also quantitatively describe the impact of cutting these ligaments, even though we're using a very low dose protocol, which significantly spares the patient of radiation dose. So with that tackled, we also wanted to look at another complex joint. We looked at the temporomandibular joint, which is also known to be quite a complicated joint. And it also has a lot of indications or some disorders that affect it, ranging from a number of causes. But and in some instances, you might end up needing an implant, right? But how it's assessed is basically by using these simple measurements, which do not give you any information on the actual motion that's happening at the joint. And if you want to design an implant, you actually need to understand what is happening at the joint and not just by how much the patient is opening the mouth of the jaw. So with that in mind, we're trying to see if there is value in using dynamic CT to look at this particular joint. And we started this in what we call a phantom study, so a mock-up, so not an actual patient yet. So for that, we built this model, a 3D printed model of the mandible based on CT scans. And we mounted this on what we call a Stewart platform. It's a 6 degree of freedom motion manipulator. And maybe some of you might be familiar with it in flight simulators or this car racing games where basically you can manipulate the structure in 6 degrees of freedom. So we basically mounted our 3D print on this structure. And then we wanted to simulate motion of the jaw whilst we are acquiring these dynamic images. So the motion we looked at were these motions all combined together. So the motors were programmed to replicate these type of motions. And the processing remains the same. Again, we have a segmentation to delineate the structure. And then we have a registration step where we try to align all the time points to what we call the static image. And from that, for instance, now you can track the trajectory of a point in 3D space. So now what you're looking at is the actual motion of the mandible in 3D space by virtue of the different motions that we computed. So one thing that also came very obvious throughout these experiments was the fact that, well, even if you're using the scanner's most advanced settings, we observe that if the patient or if the subject is moving a bit too fast, you still have these motion artifacts here. And you'll sort of see it in this particular image where the quality is not so great. And it became more apparent when we tried to do experiments on the knee, where the image quality was really bad. So it highlighted the fact that we still needed to further improve the scan protocol. And for that, what we relied on was the cardiac mode, which I described earlier on, because it's one of the very few organs that's, well, it's actually very challenging to scan because it's equally beaten. So we were like, okay, if it's a protocol that exists, and most CT scanners have this cardiac protocol, we wanted to see if we can just hack the CT to try to think it's scanning the heart, but then we put a knee or an ankle or a moving musculoskeletal structure in there and see if we get better quality using that cardiac mode. And actually, it turned out to be the case. So here is the protocol we're using before, the CNE acquisition, where you still see these disturbing motion artifacts. And on the cardiac protocol, it's much less. At least we realized that using this in our quantitative workflow resulted in better results than using these type of images. So to give a bit of a summary of this part, we've noticed that we could detect subtle changes in kinematics by cutting some ligament, even though we're using a very low dose scan protocol. We also realized that we can use the cardiac scan mode to significantly reduce the motion artifacts. So we basically have a protocol that is low dose that can also allow us to get useful images and quantitative calculations from these type of images. However, there were still a few challenges. One of them being the fact that you needed to manually segment some structures. Now, I know, at least from my interactions with the orthopedic surgeons in our facility, they are not fans of spending time segmenting structures. So it's a bit of a challenge to have orthopedic surgeons or radiologists to spend time to do that, because they rather spend it on doing much more productive things than segmenting structures. And on the other end, we're describing motions, but the reference frame is based on the CT's global reference frame, which is not the most relevant, especially you would want to describe things using the anatomical reference frame. So with that said, it leads us to the next block, which was aimed at developing a process that can, one, automatically do some of these things, but also allow us to do these type of computations in a much more relevant and representative way. So here is a bit of the workflow we went through. I would not spend so much time in it. So there's a bit of a pre-processing. We developed an automated way of actually segmenting the structures based on what is known as atlas segmentation. And this basically allowed us to now feed the result of our automatic segmentation into our registration workflow. Now, we wanted to test how good this process was. And for that, it was another extra cadaver study that we did. We built this device that allows us to also simulate motion of the knee. And basically with that, we're then going through the process that I described, right? So where you align each of these individual images to a static or a reference image, and you extract these quantitative or mathematical information that describes the way the joint moves. And in addition, you can also then propagate these segmentations onto each of these time points. So after this cadaver study, we wanted to actually test it out in real human cases. So we did some experiments, 10 dynamic images of the knee, and also 5 dynamic images of the thumb to test to see how well our segmentation workflow works. And here are some of the results of those experiments. It's evaluated using a DICE, which is a metric that describes how well your segmentation is. A value of 1 means a very good score and 0 means bad. And we were around 0.94 and 0.90, which were quite reasonable DICE scores for the application that we wanted to use it for. In addition to creating these automatic segmentations, we also created ways of automatically detecting landmarks on the structures. And from these landmarks, you can now then define more anatomically relevant or bone-embedded reference frames, which can then allow you to describe the motion, not only using the CT's reference frame, but also a bone-embedded reference frame. So to summarize this part, we also now have an automated approach that's significantly saved time in the segmentation. We had a way of also trying to identify these landmarks that can allow us to represent the reference frames in a more relevant way. So at this point, we have a low-dose protocol. We have a way to actually analyze automatically these type of images. So the next step was then to see if we can explore some preclinical or clinical applications for 4D CT. And one of the first applications we looked at was knee and patella motion in weight-bearing conditions. Now, this is because if you look at the lower extremities, these are primarily in weight-bearing conditions, because you're either walking, you're standing, there's always some amount of loading on these conditions. However, most of recent CT scanners are actually acquired in a supine setting. So you're lying down, and therefore there's no loading, particularly on the lower extremities when you do these type of acquisitions. So what we did, or how we tried to address that, was we built this device, we call it the load-bearing device, which allows us to simulate loading conditions on the lower extremities. So sort of like a standing squat against the wall. It's basically comprised of 2 parts. So you have this part, which is locked onto the CT, and you have a second part, a counterweight system, where you can choose the weight based on the patient's weight. And we did a validation experiment in a Vicon setting where we compared a squat while you're standing versus a squat using our device. And for instance, we realized that if you use around 42% of the patient's body weight, it's quite close to when you're doing these type of motion against the wall. So this is one of the way we wanted to introduce some amount of loading on the knee, even though you're lying down supine in the system. And to test this out, we looked at around 21 adult healthy volunteers, and we ensured that these participants were healthy. So they didn't have any conditions in the past 6 months. And they went through this dynamic scan on our device. And to try to evaluate some of these kinematic information, we relied on some metrics in orthopedic metrics, such as the TTG, BO, and LPT. So these were measured on of the first image, or we call the static image, and we could automatically propagate them over all the dynamic images in time. So basically, we were computing these metrics, but as a function of knee motion. And here you see the results. So for instance, this represents the TTG in function of knee flexion. And we try to compare this to other studies that were out there that tried to do something similar. And what we noticed that we had slightly lower values than what was out there. And well, this actually still requires more studies to try to understand exactly what's going on. But one of the things we know is the fact that, well, these studies were not done in load-bearing conditions. And that's one thing on the other hand. And also, for instance, we were looking at the symptomatic and the asymptomatic leg, where we were looking at completely healthy subjects. What we also did, again, using the same concept, was from our healthy cohorts. So these were the data from our healthy subjects. We now had three subjects. So there's a study that's currently still going on. We had 3 subjects that had patellofemoral pain syndrome that underwent the same procedure. And for now, what we realized that we can actually also distinguish these patients that have the pathological condition from what we see in the healthy cohorts. But again, it's a study that's still currently going on, and we'll hope to get more insights into it. We also then try to investigate as another complex smaller joint, the trapeziometacarpal joint. And for this study, we had 15 healthy volunteers. And the motion that we are looking at is the opposition reposition motion of the thumbs. So basically the patient or the subject was actually just moving the thumb during the CT. And all the processing I described earlier on were also done on these type of images. And we were trying to figure out ways of trying to represent these type of images. So this is actually one intuitive way where you actually get to see how the bones or the joint is moving. And for instance, in this case, we're plotting the trajectory of landmarks that were chosen on the surface of the bones. So the trapezium and the first metacarpal, and then looking at how this evolved over time. In addition to that, we also created these type of what we call proximity maps that sort of give you an indirect indication of the proximity between the lower surface of, for instance, the first metacarpal and the upper surface of the trapezium. So again, like I said, we're trying to experiment with ways that we can give or present these type of images or data to clinicians rather than just showing them the mathematical equations, which would not make sense to do that, but ways of trying to give them information that can be relevant, that can be used in their clinical practice. And this, for instance, this again is a description of what we call the proximity maps, where we're looking at the Euclidean distance basically between the two bones as an indication of, for instance, the distribution of the stress on the surface of these structures. So that's a bit of everything that we've worked on. I know it's slightly a bit technical. We touch on multiple joints, but now we're gradually understanding the protocol. We now have a way of obtaining good images from our scanner. We have a way of automatically analyzing these type of images. So the next stage is to try to figure out which metrics or which parameters can be useful, that can have impact in actual clinical decision making, can influence therapy, or can influence how diagnoses are made. And for that, I'm currently working on a tool or a platform that can basically do all this in a few button clicks. So this is still a work in progress. There's an example we have on the knee, and there's that case of the thumb where you actually see these proximity maps as I described. But you can also look at the motion, for instance, of one bone relative to the other. You can choose which bone you're interested in, and the idea is that we're able to provide this and make an impact in how some of these conditions are either diagnosed or either treated, or how they are followed up. And for that, we have a little bit of a survey that we're trying to gather some input from people. So it will be great if you could also support us and help us innovate in orthopedic healthcare. So that's about it. And by way of conclusion, well, so what we've established is the fact that we have a framework because that's what we set out to do, was to build this framework. And we managed to create this framework that actually can facilitate clinical research. It can improve understanding of joint instabilities, because there are these conditions where you cannot replicate the patient's pain by just looking at static images. It happens, for instance, during a particular type of motion, and you can only do that by looking at the dynamic phenomena that's associated with these structures. And importantly, is the fact that we can do it at very, very low dose. So that's one of the main bottlenecks when people hear of dynamic CT. They are like, yeah, but you're exposing the patient to too much radiation dose. We actually managed to prove that we can do it at very, very low dose and still get good enough images that can allow us to automatically extract these type of information. So thank you very much for your attention. And here I acknowledge some of my fellow authors in a lot of the work we did. Okay. Thank you.
Thank you, Benjamin. Benjamin, you can stop sharing.
All right. Okay, great.
Yeah. Thank you, Benjamin, for this wonderful presentation, and congratulations for the cutting-edge research that you've been doing in Brussels.
No, thank you very much.
A lot of papers, isn't it?
Yes, indeed. Quite some work too.
Great. Benjamin, let us take some questions. One of the concerns with the CT scans is always radiation, right? When you compare it with X-rays. So the traditional saying goes like one CT scan is equal to 1,000 chest X-rays. So when you talk about dynamic CT, you mentioned 4D scan, right?
Yeah.
So are we increasing the level of exposure, or is it the same as a conventional CT scan?
So that's what I was trying to emphasize, the fact that we spent so much time on really trying to significantly reduce the radiation dose, because what we realize is that we're particularly interested in just the bony anatomy, right? So with a very low dose, you can still at least get the external of this bony anatomy. And because we are relying on robust image registration techniques, even if the bone is not entirely there, you still can gather this enough information. So currently, for instance, our exposure is around, I'm going to take a quick look, it's around 0.06 millisieverts. And if you were to compare that to a chest X-ray, for instance, that's 0.02 millisieverts. So it's a dynamic scan, where you're having more information, but the radiation dose is significantly
less.
Yeah, exactly.
Okay, is this like a 3 times that of a chest X-ray, is it?
Yes, yes.
That's quite less, isn't it?
Yes, yes. And also the thing is, you are also looking at extremities. So you don't have what we call radiosensitive organs, right? Obviously the radiation dose will be higher. For instance, if you want to look at the neck region, then you have more radiosensitive organs. Or if you're maybe going to go to the hip, then these doses might slightly be higher. But again, we've proven that you can significantly bring this down and still get quite useful quantitative information.
Thank you, Benjamin. And Benjamin, when we talk about dynamic CT scan to orthopedic surgeons, we always look for clinical applications. Yeah. So from your presentation, as well as some of the research that I actually went through, is the greatest applications have been in the knee joint. Yeah. And especially the one that you mentioned, the excursion or the movement of the patella along the femoral trochlea. So you can look at, because I'm a knee surgeon basically, so you can look at the entire range, how the patella goes in the femoral trochlea, and look at how much subluxation occurs. So that is, I think, the biggest advantage, isn't it?
Yeah, I agree. So that's indeed one of the biggest advantage. And it's also stemming from the fact that the knees, and you will probably tell me the most of it, it's one of the challenging joints to fix, because there's still a lot of patient dissatisfaction, even with all the technology that's being thrown at it, right? So in my opinion, we still need some extra information to be able to know how to be able to actually deal with this. And these are some of the challenges that we don't have answers to based on the current imaging technologies we have. And these are where dynamic imaging can give a bit more context. Another joint that's also quite interesting is the thumb that we showed, because now what's also becoming quite common is arthroplasty of this joint. So where they're actually placing an implant, but it's completely a different mechanics, because you're replacing a saddle joint with a ball and socket, similar to what they do in the hip. So the mechanics there is not understood. And this is where dynamic CT can give us more insight, because if you look at the end motion, if you were to do this at the tip, it doesn't look that different, but what is happening at the joint could be is completely different. And by dynamic CT, we can get more insight into these type of procedures.
And Benjamin, yeah, just going back to the knee. Now,
Mhm.
in the images that you've shown are primarily in the sagittal plane, right? For example, the ankle you've shown the sagittal, but I'm sure you can have images in all angles, right? You have in all
Exactly. Yeah. Yeah.
because that is critical. Because in the knee, if you want to see the patella on the femoral sulcus, you need to have an axial image as well.
Mhm.
Because
Yeah, but yeah,
that's very
yeah.
yeah. Because
Yeah.
the reason I'm asking is the images that you showed were more with the ankle.
Yeah. No,
And
but
the other, I feel the other clinical application where we have relied on a cine radiography or a dynamic fluoroscopy for the wrist. For
mhm.
example, in a carpal instability,
Yeah.
where you have these subtle, there are a lot of instabilities in the carpals, right?
Yeah.
So previously, one of the imaging modality was to get a cine radiography or a dynamic fluoroscopy. So again,
Mhm.
we have an advantage with the dynamic CT scan. Am I right?
Yes, exactly. You're right. And indeed, so the advantage here is you're basically, it's a complement on the modalities we have. You already have your 3D information because it's a CT, and you have the time aspect of it. So you still have your 3D. You can visualize it from whatever plane you want, and you have this added layer on of dynamic information. Now it's interesting you bring up this fluoroscopy. One of the main challenges with dynamic CT is the fact that, well, it's not readily available in a lot of institutions, right? So I described that, especially if you want to look at the knee, you need these wide beam scanners because you want to capture the entire knee joints. You also need these fast rotation scanners, which is not necessarily available in all facilities. So one of the areas of research we're working on is to try to lift. So we, for instance, from a fluoroscopy image, we're able to fit a 3D model to that image, and then from that estimate is dynamic imaging. So basically, we're taking low dimensional images and lifting them up to the 4D capabilities. And we can do that because we actually have data on the real dynamic images. And there are a lot of generative AI applications that allow you to do this type of information. So it's still an area that is very open to a lot more research.
Thank you, Benjamin. Benjamin, I think that's all the questions that we have for the session. Thank you for this wonderful presentation, and congratulations once again for all the research that you do in Brussels.
All right. Thank you very much. And it's a great honor to have been on your show. And I know a lot of people enjoy it. So I'm proud you allowed me to also be there on your show. Thank you very much.
Bye-bye.